Audio check 1 2 3. Audio check 1 2 3.
Good afternoon. Hello, hello. Can I please ask the honorable delegates to take their seat and country representatives, please? Representatives from the countries can sit in any seat. There's a delegate, I think, or delegate one. It's kind of complicated today because I see some nameplates for countries and I see some plates for delegates. So it should be all delegates or should be all country names? Not good. We apologize for that inconvenience. Thank you. But let's start anyway. We apologize, but as you know, we were also working in the Directing Council and we are very well advanced in the agenda. It is my honor to moderate the fourth and last briefing session, advancing the health equity agenda in the Americas. And this is very important. This is a top priority. So I thank you for attending. Today we will have a panel of ministers with the Honorable Minister of Health of Belize, the Vice Minister of Health of Bolivia, and the Head of Office of Cooperation and International Affairs of the Ministry of Health of Chile. So we expect a very lively and very good, rich discussion. We are going to start with opening remarks from the Director of the Pan American Health Organization, Dr. Jarbas Barbosa. And without further ado, Dr. Barbosa, the microphone is yours. Thank you.
Thank you, Marcos. These days have been very busy for all of us, so I think that leaving the directing concession, coming to the technical brief, but I think that this is also the best way to have you all here around these very important topics that we are discussing during these technical briefings. And today is one really very important topic for all of us. I want to welcome the Honorable Minister Bernard Belize, the Vice Minister of Promotion, Epidemiological Surveillance and the Interculturality of Bolivia, Dr. Maxi Enriquez Nava, Dr. Raquel Child, Head of Office Cooperation and International Affairs, the Ministry of Health of Chile. Thank you for joining us today to discuss one of the most important and challenging issues that we face in our region when it comes to health equity. The region of the Americas is one of the most unequal regions in the world. Almost 7% of the region's wealth is in hands of 10% of the population. Since 2015, the region has been experiencing a deterioration in welfare levels, a stagnation in educational attainment, and a rise in poverty rates. The COVID-19 pandemic exacerbated and highlighted these inequalities with a great impact on health and a healthy future for our populations. Almost 45% of people under 18 years of age are currently living in poverty. In 2022, hunger affected 56.5 million people in the region, 49.5 million in Latin America, and 7.2 million in the Caribbean. And this number has grown by 30.2 million since the outbreak of the COVID-19 pandemic. The region's life expectancy at birth fell by 3 years between 2019 and 2021, from 75.1 years to 72.1 years. This is the largest drop experienced globally. In order to achieve more equitable societies, we need to focus on the social, economic, and political conditions that hinder the ability of certain populations to enjoy the highest attainable levels of health and well-being, including access to quality health services. Many communities and people are currently in such a situation of vulnerability that their right to health is not granted. Indigenous people, people of African descent, low-income populations, people living in informal settlements or remote areas, migrants, LGBTB plus communities, women and girls, as well as sexual minorities are part of those populations for which the socioeconomic disadvantages combined with racial and gender discrimination are disproportionately impacting their health and well-being. Health equity is at the heart of what we do at PAHO. It's embedded in the Sustainable Development Goals, central to PAHO's strategic plan, and is key to the 5 strategic pillars I announced at the start of my tenure as regional director. Member states adopted several mandates to improve health equity in the region, yet the progress towards equity has been limited and slow. With approximately 6 years remaining until the end of the commitments towards the SDGs, we need more urgent and better actions to reduce health inequities. Initiatives and strategies that address social determinants of health and health inequities, including gender, equality, and ethnicity, are good examples of how we can make our health systems and programming more equitable with human rights as a guiding principle. We will hear from Belize about how engaging women from the Garifuna community in Dangriga and integrating intercultural approaches help to address barriers in vaccine access. Vice Minister Max Enriquez from Bolivia will give interesting examples on integrating an intercultural approach into health systems and primary health care, and the head of international affairs, Raquel Child from the Ministry of Health of Chile, will speak to how the reform process is helping to reduce health inequities. We need to systematize, scale up, and institutionalize these encouraging experiences so that they can become a part of the functioning of our health systems. I fervently believe that the region of the Americas can advance in reducing health inequities and in ensuring that the unique and differentiated needs of the populations and communities in the regions are met. This is why I created the new Department of Social and Environment Determinants for Health Equity, to collectively, with countries, move forward the achievement of universal health coverage so that all individuals, families, and communities in the region of the Americas have equal opportunities to live healthy lives. I'm looking forward to hearing the experiences from our distinguished panel members on how they are achieving more health equity in their countries, and I hope that their stories can serve as an inspiration and example for others. I now hand back the floor to our Assistant Director, Marcos Espinal, who will moderate the session. Thank you.
Thank you very much, Dr. Barbosa, for setting the tone in this very important briefing about equity. Now let's hear from a video, voices from populations in situation of vulnerability, so you can start experiencing or seeing the nature of this problem. Thank you. Can we have the video, please?
Yes.
Thank you.
Todos necesitamos aporte, todos necesitamos cuidado, todos necesitamos todo. Son muchos problemas que hemos venido enfrentando desde hace muchos años.
Nadie, absolutamente nadie es inmune al racismo y a la desigualdad.
En todos los sentidos, a nosotras se nos discrimina, primero por ser migrante, segundo por ser mujer, tercero porque se dice que la trabajadora doméstica es la que no estudió.
Abordar las circunstancias particulares de los afrodescendientes es también abordar la situación de salud del conjunto de nuestras sociedades.
Hay una necesidad fundamental de que existan políticas públicas relacionadas con los pueblos indígenas y su salud es fundamental y es clave la participación activa de las juventudes indígenas.
Un poco más de conciencia y nos respeten nuestros derechos.
Estamos prestos para poder articular acciones en vías de fortalecer las instituciones para que garanticen ese servicio a la salud.
Esa es nuestra idea, nuestra lucha.
Es fundamental escuchar las voces de la niñez, las voces de las juventudes, de las mujeres, para poder transformar o poder crear políticas públicas y a la vez transformar las instituciones que aplican estas políticas públicas.
Estamos sobre representados en materia de pobreza. En la región de América Latina, antes de la pandemia, alrededor del 80% de la población en situación de pobreza en América Latina pertenecía a pueblos indígenas y pueblos afrodescendientes.
Sabemos que la mayor parte del trabajo doméstico lo hacemos las personas migrantes. Yo soy nicaragüense y migré a Costa Rica. Cuando nosotras migramos a un país, ahí donde tenemos como las peores trabas.
La visibilidad estadística es clave para avanzar en la solución de los problemas estructurales, de los problemas sistémicos que afrontan los afrodescendientes, incluidos problemas relacionados con los determinantes sociales de la salud.
Nosotras lo que estamos haciendo es tratando de luchar para tener a nivel de la región un salario mínimo, contrato por escrito y que sea de ley, que podamos ser inscrita ante la seguridad social, porque no en todos los países es exigido y no siempre para los empleadores pues es necesario.
Hay una infrarrepresentación de los afrodescendientes en las instancias de gobierno, en los espacios de decisión que los afecta, por supuesto, naturalmente, incluso no solo en el sector público, sino también en el sector privado.
Debe haber en nuestros pueblos indígenas un diálogo intergeneracional, pero también se les debe brindar como las herramientas necesarias para poder transmitir esos saberes o poder transmitir lo que aprendemos y la formación de facilitadores, que es una experiencia que la tenemos desde la Red de Jóvenes Indígenas de América Latina y el Caribe, en articulación pues con OPS.
La OPS nos ha venido apoyando y esto ha servido primero para que muchas compañeras en la región tengamos la oportunidad de poder conocer nuestros derechos y ahorita precisamente estamos trabajando para una encuesta y encontrar los hallazgos principales de la debilidad que tenemos como trabajadoras, en donde nos están fallando los empleadores.
Nos encontramos con que hoy la conciencia institucional está creciendo de manera positiva y que se está reconociendo de manera positiva la importancia crítica que reviste la cuestión de los afrodescendientes para el abordaje de ciertos problemas globales, y la cuestión de la salud no ha estado al margen de esta realidad.
Hay que entrar en clave de diálogo intercultural para poder entender y comprender a través de la metodología de diálogo de saberes, que va muy cercana también con lo que llamamos en los pueblos indígenas las mingas de pensamiento. Se puede de algún modo empezar a ver qué ocurre con estos temas en los pueblos indígenas.
Ahorita estamos apostando a una agenda regional, a que todos los países en general puedan tener acceso a la seguridad, a un contrato por escrito, salario mínimo, y que todos los derechos sean iguales, sean nacionales o migrantes.
Ahora mismo estamos trabajando en una declaración internacional sobre la promoción, la protección y el pleno respeto de los derechos humanos de los y las afrodescendientes a nivel universal. La invitación es a que las autoridades, en este caso en el ámbito de la salud, se involucren en estas discusiones y que contribuyan a abordar los distintos aspectos que tienen que ver con el reconocimiento, la justicia y el desarrollo de los afrodescendientes, y para el caso particular en el ámbito de la salud.
Escuchando la voz de las juventudes, escuchando la voz de las mujeres y de la niñez, vamos a poder aportar para poder transformar o poder crear políticas públicas y a la vez transformar las instituciones que aplican estas políticas públicas.
Se está poniendo en valor la medicina tradicional afrodescendiente, que no solo tiene impacto en términos de la medicina propiamente dicha, sino que también remite a la necesidad de preservar esos entornos culturales, esos ecosistemas donde habitan estas poblaciones, y que por supuesto se encuentran también esta riqueza en materia de biodiversidad, de plantas medicinales.
tratar de ir creando conciencia entre los empleadores, que sabemos que cuesta mucho, pero esa es nuestra idea, nuestra lucha, que algún día podamos llegar por lo menos a aumentar este porcentaje de personas que tengan un poco más de conciencia y nos respeten nuestros derechos.
Well, there you have it. Faces, faces, faces in the most inequitable region in the world. We grow economically, but the wealth is not distributed fairly. And the gap continues widen. It is the most inequitable region of all the 6 WHO's regions of WHO. So bear that in mind. We have a long road to walk still. It is my pleasure to introduce the Honorable Minister of Health and Wellness from Belize, Honorable Kevin Bernard, who has been very busy this week and in several... Sorry? What? No, I made a mistake. My fault. Yes, sorry. Honorable Minister, you go... Hang on there. So it's about progress and challenges in health equity. I was going to undermine my own director, Dr. Jerry Ekman. I'm so sorry, Jerry. The floor is yours. My apologies.
The most important are the voices of the countries. Good afternoon, everybody. Yes, after hearing the voices and seeing the faces, I think, and we all knew, everybody who's here knows how far we still have to go. So we know that the economic situation in the Americas has been adversely affected by slowdown in economic growth in most of the region's countries, with persistent high rates of unemployment, poverty, food insecurity, and inflation. So when we look at progress on the SDGs, unfortunately, and this was very much enforced last week during UNGA, only 25% of the goals, or the SDG goals in our region, are on track. 50% are moving in the right direction, but they're going too slowly. And the remaining 25% are even regressing. And even before the pandemic, progress towards meeting the SDG goals was slow. It was uneven among the countries in the region. And the current post-pandemic context presents new challenges, threatening even more the achievement of the agenda, but are also opportunities, and we're going to also look at those. But for example, the SDG 3 data highlights modest reduction in mortality rates in most of the goals, although the challenges in terms of equity persist. On the positive side, for example, child mortality rates have decreased, and also the gap between the countries has narrowed. However, there are indicators that are not only worsening regionally, but have also shown increased inequality between the more and less developed countries. So to meet the SDG 3 targets, we've talked about that. Last year, the region adopted a policy about that. It's necessary to advance action on the interconnected SDG agenda. It's not possible to just focus on the health SDG to advance. And it's important to not only improve the health levels in the countries, but also to reduce the inequities, which require an intersectoral approach and working with territories and communities in situation of vulnerability. And in this context, I want to highlight that vulnerability is not considered in terms of the individual attributes of people, but as the result of the condition in which people and communities live. Vulnerability in health is expressed through an increased likelihood of health problems, the accumulation of health exposures, and the damages and negative impact on well-being over time. And again, it underscores the need for an intersectoral approach to improve health outcomes and health equity in the region. But I would like also to focus our attention on a critical, important issue. Health inequities are per definition unfair and avoidable. And the examples exist that I'm going to give a few of, by no means exhaustive, of effective interventions that have been implemented to address health inequities. Let me start through the life course with the young ones. Investing in health and well-being of children from an early age is essential to ensure a healthy and an equitable future. Early development programs for children and adolescents have proven to be highly effective in reducing inequalities. For example, several countries in our region have implemented successful early development programs. We all know Chile Crece Contigo from Chile, De Cero a Siempre from Colombia. And these programs have shown that intersectoral action can and have improved our children's health, their well-being and their development, enabling a more equitable future by investing in them from an early age. There's also an interesting example, a study from Jamaica, where we found that over a period of 20 years, children from poor families who received quality stimulation at an early age ended up earning 25% more as adults than of children who did not benefit from those interventions. And what is very important here, that these kind of interventions can break the cycle of poverty. When we move up in the life cycle, recognizing the intimate relation between employment and health, promoting entry-level quality jobs is one of the examples where we can also make impact. I'm putting a lot of emphasis on actions of other sectors, because that's really important, of course, to move the equity agenda. But I'm also going to give some, I'm going to talk a little bit more also about what the health sector themselves can do. So promoting entry-level quality jobs for youth is crucial to prevent precarious trajectories in the labor market. An example from Peru, having a high-quality job as a young person increased 12% the probability of having a high-quality job later in life, closely related to better work benefits, better pay, more job satisfaction, more stability, and all of this, of course, extremely important for the health and well-being of the workers and their families. In the region, policies to address the problem of occupational insertion faced by young people, especially at the beginning of their careers, have been implemented since the 1990s, with different results of sustainability and results. Some examples are youth employment on youth employment promotion strategies are Proyecto Joven from Chile and Peru, training for the work on focus of employability, Jóvenes en Acción in Colombia, Mi Primer Empleo in Mexico, and labor legislation on first employment. For example, La Ley de Aprendices in Brazil, the youth labor regime in Peru, and also more recently, some countries such as Canada and Uruguay have focused on the quality of employment in addition to occupational insertion. Uruguay, for example, has the Ley del Empleo Joven, and it has made it possible to strengthen labor relations and the rights of young workers, regulate the employment market, include wages, and actively promote the empowerment of workers in the exercise of their own rights. And as was said very clearly by our representative of the informal workers, this is really extremely important for health. For an informal worker, not having health means no income, and income is obviously very strictly linked to possibilities for moving up. As we age, access to care and social protection becomes an increasingly important determinant of health. Ensuring that older people have access to adequate health care, but also proper retirement pensions to ensure a decent life, among other social benefits, is essential to reduce inequities at this stage of life. Again, an example here is the National Strategy for Healthy Aging of Costa Rica, whose main line is the multi-sectoral commitment to healthy aging based on the life course, focusing on addressing the social determinants of health of the elderly, going beyond the action of the health sector through intersectoral action. Then I think what is important here is to show, please, next, that change is possible. Change is possible to achieve significant progress in reducing health inequities by addressing them throughout the life course, by implementing adequate social policies. And Finally, action on social determinants of health does not happen only outside of the health sector, which is very often thought. I want to highlight the vital importance of incorporating the social determinants of health approach in our clinical or in our disease programs, especially in primary health care. We know that health is not shaped by health services, but to a very large extent by their communities, by their social environments. So working to reduce health inequities and address social determinants is not only an ethical imperative, but it's also a matter of effectiveness by making our programs and systems more effective by reaching people that we normally do not reach. I want to give here a last example. In Chile, to better understand why their cardiovascular health cardiovascular program did not have the expected results, an analysis of equity was carried out, and we saw that an important group of the population was not being reached, the informal workers without social protection who did not regularly attend health services. So addressing the social determinants of health of non-communicable diseases in this case and identifying the barriers to achieving adequate levels of effective coverage of our programs are key steps to improve the capacity for prevention, for diagnosis, for treatment and the control of a range of diseases such as cardiovascular diseases, chronic respiratory diseases, mental health, etc. Tools like Innovate can help countries with this process. Finally, without acting on health equity and without acting on our social determinants, on the social determinants of health, it will be difficult, if not impossible, to achieve better health, to achieve well-being for all, and to honor the right of health for everybody. Thank you very much for attention, and back to our moderator. Thank you.
Thank you, Dr. Ekman, Director of Social and Environmental Determinants for Health Equity in PAHO. And you saw it, there has been progress, encouraging results, but we're not yet there. We have a long way to go. So now, yes, now it is my distinct pleasure to introduce Minister of Health and Wellness of Belize, the Honorable Kevin Bernard, who is going to address you on working with women's organization and community engagement processes for reducing hesitancy against the COVID-19 vaccine. Honorable Minister, the floor is yours. Thank you.
In terms of Belize's approach to reducing COVID-19 vaccine hesitancy and how we were able to engage the women in our communities, especially in the southern part of the country, where there was, in the statistics had shown us that there was a lot of vaccine hesitancy in that area. As you are all aware, Belize is a small country from the Caribbean and Central America. We are 8,867 square miles. We have 6 districts within our country with 4 health regions in the north, in the west, in the city, and down in the south. We are one of the only English-speaking country in Central America. We have a multi-ethnic population, and I will get into that when I explain the purpose of us engaging the women down south. We have the Creole, the Mestizo, the Garifuna, as Director has mentioned, the Maya, East Indian and Mennonite and Asian population. Small population of a little over 440,000 persons living in the country. Now, when you look at the statistics for Belize in 2021, you will notice, and I'm just highlighting here the statistics on women that were able to, we were able to target in terms of vaccination. You will find that 54% of our women were vaccinated in that first year, immediately after the COVID hit us. And in 2022, we gained another 4 points on that at 58.1%. And 2023, of course, the COVID-19 no longer is a pandemic, but has been declared an endemic and has seen reduction, and the hesitancy still occurs, and I'm sure it happens across the region. But I must say that in terms of the work we were able to do, it required a lot of engagement. It required, in order for us to advance the health equity agenda, as this team is about, and to reduce the vaccine hesitancy among women, we had to utilize our community health workers, but we also engage women organizations. And there is one organization in the South that was able to work along with the Ministry of Health to ensure that we were able to target our women in these vulnerable areas, especially in Toledo and the Dangriga area, where the Garifuna community and the Mayan community, from the numbers we saw that they were very, very low in terms of the vaccine uptake. And so the initiative to go out there to spread the education awareness, to ensure that we are able to target our women, especially pregnant women, because we saw where in the first instance we had deaths in women that were pregnant from COVID. The Ministry of Health decided to ramp up its initiative and target women in those areas, especially down south. And so here I'm just highlighting the phases that we did in terms of who we targeted first: our healthcare workers, persons over 60, persons with special needs. Then we went into our teachers and police officers, our judiciary and National Assembly members, and of course the tourism sector. And in all of this, we ensured that we targeted our women, especially. And so it just lists the various phases that we had. Now, what we also did was to try, in order for us to be able to get our population vaccinated, we had to send out messages. Apart from just putting out the statistics, we ensured that messages and information were out there to ensure that we could get them to be vaccinated. So here is an example where we placed out there an unvaccinated person is 24 times more likely to die compared to a person with complete primary series of vaccine. And these were targeted to women, targeted to our pregnant women, targeted to our young female as well, and of course the wider population in Belize. We had, as the statistics shown, in the year 2021, the Delta wave increased the maternal mortality rate by 6 times. And so we had to ensure that we targeted our females, especially our women. And so these are some examples that we did, ensuring that we ramped up our campaign. And we also had to take into focus the fact that we had to have, because of the mixed cultures that we had to have culturally sensitive in messaging that goes out. And that was crucial to develop, because we had to ensure that in certain pockets of our communities, there are certain people with certain beliefs, there are certain people with certain values and concerns. And so we had to look at all of these things in terms of addressing those issues. And so from the Belize perspective, we were engaging, and you will see here in the slides images of where we went down in the Dangriga community, the southern community, through the Ministry of Health and Wellness. And of course, what we did was to try and ensure that we could empower our women through these healthcare services, and making sure that they were also benefiting from accessing the healthcare services, especially the vaccination that we needed them to get. And from a country's perspective, we have been able to ensure that we are at around the 58% of our population was able to be fully vaccinated. And I think that's a high target. And when you look at the target population that we targeted from age 5 and above, we were able to have a high rate of about 72%, I believe, that we were able to do. So what we did in terms of the engagement with POA, and POA stands for the Productive Organization for Women in Action. They work to eliminate discrimination and gender inequity in the southern Belize, focusing mainly on combating the spread of HIV and AIDS and other diseases. But because COVID was upon us, they also went out with the Ministry of Health, the PAHO team, to increase the vaccine uptake in that southern part of the district. Young persons were trained, young women were trained. We did a lot of home visits along with POA in the rural communities to conduct, allowing these families to have access to the information. And they were able to sit and ask necessary questions and get response from the Ministry of Health team along with the group from POA. And so it's community engagement that we felt allowed us to be able to have seen a major increase in the uptake. And again, as I said, we had to tailor our outreach in terms of that sector of the community. There was a lot of training and capacity building that was done, working together with these groups. And so we were able to address some of the barriers that we saw. And so POA worked closely with the Ministry of Health and Wellness to ensure that these outreach programs were organized in locations that people had easy access to. Mobile vaccination clinics. We offered transportation support to these persons so that we could get them to come into because they live in very remote areas. And so the ministry had to ensure that persons were more hesitant in going to the health center, which is miles away on very rough roads. So we had to get out there. We went into the communities, set up mobile sites, and work along with these groups. And so with all that, we were able to ensure that we target our community. And so that's some of the experience I wanted to share in terms of what Belize did in ensuring that our women were vaccinated, and we targeted our women. And I want to encourage that. And just as we have that 58%, we continue to ensure that we continue to work hard in that community, in those certain communities, with our female, so that they can and all be part of the services that we provide. And to, as our motto says, providing quality healthcare to all. So thank you very much.
Excellent example of empowering women, community engagement to ensure reduction of inequities and making sure they all have access to the health system. So thank you very much, Honorable Minister Bernard. This is reassure us that it's energizing us to continue working in the reduction of inequities in the region. Now, as you know, Chile, it's undergoing a health sector reform, and it is important not to miss the boat and ensure that that health sector reform take advantage and explore opportunities for reducing health inequalities. And Chile has been clear that this is one of the top priorities for them. So I'm delighted to ask Raquel Child, head of the Office Cooperation and International Affairs at the Ministry of Health of Chile, to give us a flavor of how this health sector reform in Chile is taking care or taking opportunities to address health inequalities. Ms. Child, thank you.
Muchas gracias. En nombre de la Ministra de Salud, agradezco la oportunidad de estar presente en esta sesión en la que haremos una breve descripción de lo que estamos enfrentando en materia de reforma al sector salud y en este caso reforma, como señaló el doctor Espinal, reforma dirigida a disponer de una atención primaria disponible para toda la población. La Organización Mundial de la Salud define los determinantes sociales de la salud como las circunstancias en que las personas nacen, crecen, trabajan, viven y envejecen, incluido el conjunto más amplio de fuerzas y sistemas que influyen sobre las condiciones de la vida cotidiana. En este contexto, la OMS señala que estas fuerzas y sistemas incluyen políticas y sistemas económicos, programas de desarrollo, normas y políticas sociales y los sistemas políticos en los que las personas se desempeñan y se desenvuelven. Y como también señala la definición de OMS, las circunstancias y condiciones de vida son muy diferentes entre los diferentes grupos de la población, lo que genera diferencias en materia de salud individual y en materia de acceso a salud. Es posible que sea inevitable que algunas de estas condiciones sean diferentes, en el cual caso se consideran desigualdades. Pero también es posible que estas diferencias puedan ser innecesarias y evitables, lo que consideramos una inequidad, como ya se dijo anteriormente. Por consiguiente, se requieren metas apropiadas para políticas diseñadas que aumenten la equidad. En Chile, dadas las diferencias en las condiciones de acceso a salud, estamos viviendo una etapa de cambios en la estructura del sector salud. Estamos formulando una reforma de salud que busca el acceso universal a la atención primaria de salud sin distinción de ingresos ni seguro de salud disponible. Históricamente en Chile, el acceso de las personas al sistema de salud ha estado marcado por variadas incertidumbres, dependiendo del sector al que uno acceda. Quienes están y se atienden en el sector público presentan incertidumbre de oportunidad y de calidad. Pero por otra parte, quienes acceden al sector privado presentan una importante incertidumbre de costos, habiéndose así configurado en el país una falta de dignidad por una parte y de seguridad social por otra en materias sanitarias. Observamos también diferencias significativas y producto de lo anterior en los indicadores de salud observados entre diferentes grupos sociales, ya sea que los grupos sociales los estratifiquemos por nivel de ingreso, ocupación, educación u otras variables relacionadas con el estatus socioeconómico. Por ejemplo, la mortalidad infantil, ámbito donde nuestro país exhibe resultados similares a los países de mayor nivel de desarrollo, muestra cifras en comunas de bajos ingresos que duplican aquellas cifras de mortalidad infantil obtenidas en las comunas de altos ingresos del país. En cuanto a otros indicadores de salud, como la sospecha de diabetes, medida en la Encuesta Nacional de Salud en el año 2017, esta alcanzó un nivel 3,3 veces más alto en personas con menor nivel de escolaridad, quienes tenían menos de 8 años, en relación a las que tenían más de 12 años de escolaridad. Y, según el último Estudio Nacional de Discapacidad efectuado el año 2022, un 17,6% de la población chilena presenta discapacidad, siendo esta cifra mayor en mujeres, 21,9% en relación a los hombres. O sea, un nivel de inequidad significativo. Asociado a lo anterior, el porcentaje de personas con discapacidad es mayor en los quintiles de menores ingresos que en los mayores, 21,9 versus 13,5 porcentaje de personas con discapacidad. Por ello, se sostiene que la gran condicionante estructural de las inequidades en salud es la inequidad social. La evidencia científica indica que los resultados de salud dependen en un 50% de los determinantes sociales de la salud y solo un 25% depende de las acciones sanitarias. Basado, entre otros, en los antecedentes señalados, Chile está desarrollando con mucho esfuerzo una reforma integral al sistema de salud que tiene como corazón la atención primaria, la que mediante una agenda de transformaciones integrales avance en otorgar acceso universal, oportuno y de calidad según necesidad y que aborde las condiciones de vida y vulnerabilidades sociales, que modernice el sistema y que contribuya a mejorar la dignidad en los cuidados de las personas, generándose una mayor protección financiera y un más eficiente uso de los recursos. Hoy por hoy, las personas no sienten que el sistema de salud responde a sus expectativas en cuanto a dignidad, incluyendo aspectos de trato, protección y acceso. Y como ya dije, en quienes se atienden en el sector público, el 80% de la población del país, o el sector privado. Los principios y valores que sustentan la propuesta de reforma de salud actualmente en discusión son tres. En primer lugar, el derecho a la salud, universalidad y solidaridad. Es decir, se impone al Estado deberes en el ámbito sanitario para toda la población, sin discriminación alguna, pero con una intensidad proporcional al nivel de desigualdad. Esto nos permitirá transitar en una universalidad nominal, desde una universalidad nominal a una universalidad efectiva. En segundo lugar, el siguiente principio es el de la libertad y la justicia social. La libertad existe en función de la existencia de igualdad y de justicia, y cuando se presentan oportunidades para escoger entre alternativas reales. Hoy en Chile la población no tiene, y el 80% de la población que nos atendemos en el sector público, tenemos dificultades para elegir entre alternativas reales. Y en tercer lugar, el tercer principio y valor es el de la participación y la legitimidad social. Consideramos que a la participación como un mecanismo que permite que la comunidad exprese sus preferencias y expectativas y, por otra parte, sirva a instancia de fiscalización por parte de la comunidad sobre la calidad, la efectividad y oportunidad del servicio y el uso eficiente de los recursos, contribuyendo así a la generación de salud en su población. Para terminar, esperamos poder que en los próximos consejos directivos de OPS informemos los avances en nuestro proceso de reforma, el que modifique el acceso a la salud de la población del país, basándonos en una atención primaria universal, accesible y resolutiva. Muchas gracias.
Muchas gracias, doctora Child. Bueno, y continúo en español para aquellos que pongan los headphones, así nos movemos un poco. El doctor Max Enrique Nava es el viceministro de Promoción, Vigilancia Epidemiológica e Interculturalidad de Bolivia. Y nos va a hablar sobre integrando un abordaje intercultural e integrador en el sistema de salud, resultados y procesos. Doctor Nava, Enríquez Nava, el micrófono es suyo. Es un placer tenerlo por acá. Gracias.
Muchísimas gracias, doctor. Muy buenas tardes a todos ustedes. Vamos a tratar de hacer una presentación bien resumida de lo que para nosotros implica la salud familiar como un derecho en el Estado plurinacional de Bolivia. Bajo un análisis de situación en la cual consideramos que hay un 70% de la población está adscrita, es decir, inscrita a lo que es el Sistema Único de Salud, y tiene un acceso a la salud universal y gratuita en nuestro país. La Constitución Política del Estado reconoce 36 nacionalidades indígenas originario-campesinas y estas naciones indígenas representan el 44% de nuestra población del Estado plurinacional. Existen aún más brechas de acceso para las mujeres identificadas en salud, trabajo y seguridad. 34% de las familias tienen como cabeza de hogar a una mujer. Esto dentro del marco constitucional en nuestro país ha ido avanzando desde el reconocimiento en la legislación nacional y en programas buscando la equidad en salud. Y ahí tenemos los artículos 18 a 37 que están reflejados en la Constitución Política del Estado. También se reflejan en el eje 10 del PDS, del Plan de Desarrollo Económico Social de nuestro país. Las mujeres como construyendo la nación para una Bolivia, con un vivir bien, que está dentro del Plan Nacional para la Igualdad de Oportunidades. Una ley que hace énfasis en la despatriarcalización en la salud con una equidad de género. Tenemos la ley 031 que habla del marco de las autonomías. Nuestro país tiene 9 departamentos, los cuales son autónomos con diferentes tipos de descentralización. Hay una normativa para el ejercicio equitativo de la salud como un derecho, y entre estos hablamos del derecho de la niñez, el derecho a que las organizaciones sociales constituidas en la base poblacional puedan ser identificadas y puedan tener su identificación y hacer sus propios desarrollos. Y esto enmarcado en el PCDI, que es el Plan de Desarrollo Sectorial Integral para el Vivir Bien del sector salud. Tenemos todo un marco legislativo que apoya a identificar estas desigualdades y a mejorarlas para dar equidad en salud. La salud como un derecho humano es inalienable e imprescriptible en nuestro país, individual y colectivo, indispensable para el goce efectivo de los demás derechos humanos, y su garantía es deber del Estado y una responsabilidad social. El derecho en salud se logra garantizando un acceso físico, acceso a un establecimiento de salud, acceso cultural con un trato digno y de acuerdo a la cultura de las personas que sea aceptable, y un acceso económico en el que el costo no sea una limitante para la asistencia pública. De las buenas prácticas en salud en nuestro país, la política de salud del Estado plurinacional está basada en la salud familiar, comunitaria e intercultural. La conocemos como la política SAPSI. Las estrategias y buenas prácticas que aplican los principios de la SAPSI, la salud como un derecho universal gratuito, incorporando la equidad y la interculturalidad para el acceso, toma en cuenta la implementación de un sistema de salud como es el SUS, un enfoque de una salud dirigido a la colaboración de múltiples niveles de Estado y en los privados o con los privados para alcanzar mejores resultados posibles en política pública de salud. El fortalecimiento de la participación social en salud es una base fundamental y una práctica que la aplicamos. Los planes municipales que incorporan un enfoque de género y el fortalecimiento a la integración de programas nacionales de atención primaria en el primer nivel. Esta política SAPSI se sustenta bajo 4 principios fundamentales. 1. La participación social, la interculturalidad, la intersectorialidad y la integralidad. Estos 4 principios van a asumir una estrategia de promoción y prevención de la salud con unos componentes fundamentales como es la gestión participativa y el control social de la salud, bajo una atención integral e intercultural. Cuando hablamos de esta pirámide y encontramos como la base los planes para la acción sectoriales, departamentales, municipales, con tácticas, medios o mecanismos como son la promoción de la salud y una estrategia, la aplicación de esta misma promoción con un objetivo, eliminar la exclusión social en salud bajo un fin que es contribuir al vivir bien para nosotros como un principio de vida. La evolución de la salud universal y gratuita ha ido implementándose bajo la creación y la determinación de algunas leyes como es la Ley 475, que ha sido posteriormente reemplazada con la 1069, en las que involucra la atención al menor de 5 años, las mujeres en salud y edad reproductiva, personas con discapacidad y la última ley que nos ampara, la Ley 1156 de la salud universal y gratuita. Estas modificaciones nos han permitido tener estos logros, los cuales podemos mencionar que antes de la implementación de este sistema único de salud teníamos una población no asegurada del 40% y posterior a la implementación de estas hemos superado el 61.8% de nuestra población beneficiaria a través del Sistema Único de Salud. Y hay una población asegurada bajo diferentes metodologías o métodos de aplicación de estas en un 38.2% que hacen a la cobertura universal de salud en nuestro país. Muchas gracias.
Gracias. Well, excelente, excelente. Felicitaciones a Bolivia, a Chile y a Belice por mostrarnos ejemplos de que sí se puede, de que sí podemos. Y lo importante es que estas prácticas sean expandidas, que continuemos, que el marco legal esté claro, definido, como ha presentado Bolivia, porque el resto viene por añadidura si hay un buen marco, si hay involucramiento de las comunidades, empoderamiento de las comunidades, de las mujeres, de los indígenas, de los afrodescendientes y otros grupos de personas viviendo en situación de vulnerabilidad, LGBTQ+I, todos, porque todos tenemos el derecho a salud de calidad y a estar incluidos en nuestros sistemas de salud. Ahora voy a abrir para comentarios y también agradecer a nuestros socios y a nuestros donantes como Cana de Estados Unidos que trabajan muy cerca con la OPS para que podamos proveer esa cooperación técnica en reducir las inequidades, en enfermedades, en factores de riesgo y todo esto. Así que, por favor, el micrófono está abierto para comentarios que pueden ser bienvenidos. A ver si alguien se anima. Chile de nuevo.
Oh, de nuevo. Gracias, gracias. Sí, tú conoces a Chile. No, una pregunta a el ministro de Belice. One question for you.
Yes.
How do you get to the different populations you have in rural areas, so on and so forth? Because, yes, I wonder how you do and how you are thinking to improve the access the people have to health services.
Thank you for that question. One of the things we do, in fact, in all of our rural communities, we do have community health centers, and we do regular mobile services in those areas to ensure that they are targeted and they can access health in those areas. So there's constant visits that are done in those areas. We do just over the weekend. We were in the north and some areas in the south where we take teams to go in and do targeting, of course, various areas because we are trying to ensure that we can get back to our immunization status pre-COVID as well. So there's a lot of areas we try to work to get in there. It's not difficult to get into the rural communities. As I said, we do have, in the regions, we do have major facilities, but then we ensure that there's community health centers in every area. We just recently increased the salary for our community health workers. As you know, they are the first person in those communities that somebody will seek to help from. And so in order for us to be able to attract more of these persons and train them to be able to provide those basic services to our residents, then we were able to get more to come on board as well. And then again, we do a lot of constant training in those areas so that we could target those vulnerable populations. So the Ministry of Health and Wellness has been engaging and making sure that those areas that are far-reached have constant visits by the Ministry of Health team.
Thank you. I don't see requests for the floor, so I know you are tired. And, as Dr. Barbosa was saying at the beginning, it's a long week. So we're going to let you go and have 10 minutes break before we resume at 2:30. But before we finish, let me ask Dr. Barbosa for final remarks on this important briefing. Dr. Barbosa, thank you.
Gracias, Marcos. No solo para, yo creo, querer conocer la importancia del tema y como es importante empezar a recorrer más las buenas prácticas que tenemos en la región. Hoy en la mañana, durante una reunión bilateral con México, por ejemplo, conocí una experiencia excelente por intermedio de la Autoridad Regulatoria de Salud de México, COFEPRIS. Trabajaron con una comunidad indígena, un pueblo originario de México, para producir una farmacopea con la medicina tradicional de esa comunidad. O sea que es una manera muy concreta, respetuosa de valorar e de preservar um saber tradicional que aí estava. Sim, eu creio que como esse também há muitas outras intervenções que temos que recorrer mais em la região, evaluar. Seguro também intervenções de caráter social. Sempre, a mim me parece que é importante que o setor saúde seja uma parte muito ativa de los processos de diminuição da pobreza, de recuperação social que estão em marcha em los países. Muitas vezes os ministérios de saúde se quedam um pouco como crendo que seu problema é só manejar os serviços de saúde, e sabemos que não é. Então, ter também uma mirada para os temas de saúde nessa abordagem multissetorial sobre os determinantes sociais, eu creio que é muito importante e temos uma oportunidade agora, porque em muitos países estão em marcha todavia programas sociais, intervenções sociais, cambios de leis, iniciativas que se estão implementando para apoiar, reduzir e recuperar o impacto negativo social e econômico que a pandemia ha produzido. Assim que muitíssimas graças a Bolívia, a Belize e a Chile por compartilhar com nós outros suas boas experiências que podem servir também de estímulo para que se pueda compartilhar mais e atuar de maneira mais direta nesse tema tão importante. Muitas graças.
Muchas gracias a todos y recordarles que a las 2:30 debemos estar en el salón para avanzar en la conclusión del Consejo Directivo. Gracias. Now I'm going to eat here.